Hi, good morning. Thank you very much for coming. It's really nice to be here to present the results of this trial, which we did, and which have been published now. So what I'm going to do today is just give you a quick run-through of the process we went through to plan the trial, to collect the data, and then try and give you an overview of the results. So the study is the VENOUS 4 study. I don't know if anyone's heard of VENOUS 1, 2, and 3. VENOUS stands for Venous Leg Ulcer Study. And I'm here obviously presenting today, but this was a large trial and it relied on a huge number of people to bring it to fruition. Some of them are here today as well, especially the principal investigators of all the sites that were involved in the study. So I don't need to tell anybody here that multi-layer compression bandage is known to be an effective treatment for venous leg ulcers. And of the bandage options available, 4-layer bandage is often seen as the gold standard. With VENOUS 1, the first VENOUS trial, showing that it was effective compared to the short stretch bandage. But in practice, there are reported to be issues with the 4-layer bandage. It's bulky, it takes time to apply, patients can sometimes find it uncomfortable and hot and difficult to kind of wear shoes with. And it also requires applicator skill to apply with the right level of compression. So in terms of innovation, there was interest in other forms of compression being delivered, delivering the same amount of high, in inverted commas, compression for the treatment of venous leg ulcers. So we noticed in talking to nurses that there was an increase in use of 2-layer compression hosiery. So this was compression kits designed to deliver the same level of compression as 4-layer bandage, but in the form of an understocking and an overstocking. So the rhetoric around these was that they would, or the logic, I guess, was that they would potentially be less bulky than bandages. Patients could put them on and off take them on and off themselves. It might encourage people to use stockings as a maintenance treatment. But this is essentially a new type of treatment for venous leg ulcers. There was a gold standard, which was the multi-layer compression bandaging, especially the 4-layer bandage. And it seems that this treatment should be compared to the existing gold standard before its use spreads more widely. In terms of the existing evidence, when we put the trial together, so the trial was funded by the National Institute of Health Research, so it was publicly funded, and we got the money to do the trial through a competitive bid. And as part of that, we have to say, okay, so what is the existing evidence base? So this is kind of a horrible graph, and I'm really sorry, but it actually kind of tries to communicate a lot of information in one go. These were the 4 trials that had been published. They all compared high compression hosiery with short stretch bandages. These are just the results in numbers, the proportion of people healed in each arm, so short stretch bandage and a hosiery arm. And this is the result in terms of the relative risk. This is the result of each trial and the lines, the confidence intervals. So the idea of the amount of uncertainty around that estimate. So the kind of key finding is when you put all the data together, you meta-analyse it, it actually found a significant risk of improved healing, so more healing in the stocking groups compared to short stretch bandage. So that was the current evidence base. These trials were not without problem. Some of them hadn't been conducted very well. They were at high risk of bias. It wasn't a robust evidence source to make decisions with. And also it didn't compare with the 4-layer bandage. So we were funded to do VENOUS 4 that looks at the clinical and cost effectiveness of the 4-layer bandage with 2-layer hosiery. So we started the trial in 2009, and we had 34 centres in England and Northern Ireland. And we recruited from all the settings that you would normally see patients with venous leg ulcers. And we followed people up who'd been recruited to the study for up to 12 months, because our primary outcome was healing. So the trial had to be long enough that a reasonable number of people had the outcome of interest. As I said, our primary outcome was healing. The reference ulcer was a term that we used if people had more than one ulcer. We only followed the largest eligible ulcer, and we called that the reference ulcer. We collected a number of different outcomes on top of our primary outcome, although that was our key focus. We measured resource use, because as I said, we were interested in looking at the cost effectiveness, and that means that we have to record every visit, every wound-related visit a participant had, how long that visit was, the treatments they received, and any other contact they had with the NHS because of their wound, so we could work out how much resource that person's treatment was costing from an NHS perspective. We looked at quality of life. We looked at change in treatment because we had started out wondering whether stockings would be more acceptable to patients. We weren't sure, but we were interested to know how long people use the treatments for. I don't have a clinical background, but when I started in wound care research, I was surprised at how much flux there is in people's treatments and the amount of treatment change. And that's not a problem in terms of doing a trial. We just have to measure it so that we can report it and present the results with that context. We looked at adverse events and we also looked at ulcer recurrence. So we did a trial, and so it's really important that we did a good trial, because actually the results of trials can be very simple. Does it work? Is it better? Yes, no. The really key issues are how well we collected the data. So just to reassure you, we worked with the York Trials unit, and we had a robust method of both generating our randomization sequence and then allocating people to either the stocking group or the 4-layer bandage group. And that was done by computer. So people would phone up and they would say, I've got a participant, they're eligible, I've consented them, and then an operator at the end of the phone would tell that person, that nurse, which group the participant would go into, either the hosiery group or the 4-layer bandage group. So it was completely outside the control of the person in front of that participant at the time. Really importantly, we did blinded outcome assessment. Healing is a subjective outcome, and so to make sure there's no bias in outcome assessment, we need to have people looking at the wounds, deciding if they're healed, who don't know whether somebody had treatment A or treatment B. That's quite challenging to do, and it's not perfect, but it's an important element of any trials in wound where healing is an outcome. So the people that we recruited into the trial, the participants, obviously had to have a venous leg ulcer, and they had to be willing to have high compression. So already we're kind of excluding some of the venous leg ulcer population and have filtering down to the people who would agree to have the treatments that we were evaluating, and they had to be adults. We tried to make the trial as pragmatic as possible because we wanted the results to apply to practice as widely as they could. So we didn't want to exclude people unless there was a good reason. And what we tried to do, we worked with patients and clinicians to try and only exclude people from the study who you wouldn't treat with hosiery or 4-layer bandage normally. And the key issue was around exudate and edema for putting the stockings on. The interventions, the 4-layer bandage, we weren't very prescriptive in terms of what the nurses could use. It had to aim to deliver 40 milligrams of mercury at the leg, and it had to kind of adhere to standard recommendations about the number of layers based on the ankle circumference. The 2-layer hosiery that people used, again, we weren't completely prescriptive. It had to be a kit, and again, it had to be designed to aim to deliver an adequate level of compression. We collected a lot of data in the trial. We collected information about the people who had been randomized, the amount of contact these patients were having with NHS staff. As I said, we measured whether people changed treatments, when they healed, whether their ulcers recurred, what their quality of life was. throughout the study. So we had a lot of data. So I'm not going to go through this. This is obviously very small and not easy to read, but this is just to show you if you're interested. So this, as I said, this study has just been published in the Lancet, and this is the patient flow chart. So if you want to, you can map what happened to the study population. It also includes why people were excluded from the study in terms of not fulfilling the inclusion or exclusion, not fulfilling the inclusion criteria. So if you want more information, there's a lot of it. So we recruited 457 people to the trial. This is just an overview, a summary of the baseline variables, a description of the study population, if you like. So it's about 50-50 men, women. The mean age was 69. I'm not going to go through it, as I said, and you can have a look at it, but this is just, on average, the people who are in this trial. So these are the results. So our primary outcome was time to healing. So let me just talk you through this. So the median time to healing, which is the time it took for half the people to heal, was about just over 3 months in each group. So then we want to adjust for things to make sure that our results are as robust as possible. So we do this and we present the results in a hazard ratio. This is a bit like looking at an odds ratio or a risk ratio, in the way that if there's no difference between the groups, you would get a number of 1. So 1 means the groups are equivalent. So as you can see, the figure is really close to 1. So in terms of time to healing, from the data we had, there was no evidence of a difference in time to healing between the 4-layer bandage and the 2-layer hosiery. This graph just presents the same information, but as a picture. So the top line is the 4-layer bandage, the dotted line is the 2-layer hosiery, and this is looking at the proportion healed over time. So as you can see, you start at the beginning of the study, and you go on, and as time goes by, more and more people heal, up to about 70% at the end of the study. And there's no difference statistically in healing. In terms of change from treatment, more people changed out of the hosiery. So we were not expecting this, but listening to Elaine's talk and talking to patients since we've done the study, it's possibly not that surprising. I don't know how surprising it is to you as the clinicians. The time it took people to change from treatment was quite long, so people weren't changing very, very quickly. So the median time to change for 2-layer hosiery was over the median time to healing. And this is a 95% confidence interval, so the majority of people weren't changing from treatment until they've been on the treatment for at least 3 months. But the reasons for this change from treatment were mixed, but in the 2-layer hosiery, 40% of people said it was due to discomfort. So we also looked at ulcer recurrence. There was less recurrence, statistically significant result of there being less recurrence in the hosiery group compared to the 4-layer group. And that was also, we also looked at time to recurrence, and the time to recurrence was shorter in the 4-layer bandage. So more people were recurring who'd had the 4-layer bandage or been allocated to the 4-layer bandage group, and they were recurring more quickly. But a big note of caution with this. The value of this study comes largely from it being a randomized controlled trial. When we look at recurrence data, it's not randomized because we can only look at the outcome occurring in those that healed. So if there were a difference in the characteristics of people who healed in the 4-layer bandage group and the hosiery group, then it might affect this finding. It's hard to see how that might be occurring, but it is a risk. So we think this is an interesting finding and one that needs exploring further, but it does need to be interpreted with caution. So, as I said, we also did a cost-effectiveness analysis. This means we collected the resources used by participants in each of the trial arms, and then we applied a cost to those. And then it's very fancy. The people who do this are much cleverer than me. It's really mathematical, but essentially what you do is you add it all up and take one away from the other. So you get a total average cost per person in one group, a total average cost in the other group. You take one away from the other and you see what the difference is. So when you do that with cost, the mean cost per person was £300 less in the two-layer hosiery group. And that was largely because people in the hosiery group had less nurse consultations. They were having less visits. Nurse visits are the most expensive part of leg ulcer treatment. So you cut them down, there's less cost. Even with the treatment change, we think we still saw this because people were having the treatment for a reasonable amount of time before they switched onto something else. When you do a cost-effectiveness analysis, the cost is only one half of it. You then need to look and see whether any savings you might be making are impacting on the quality of care or the quality of outcome for your patients. And we measured that looking at quality-adjusted life years, which are measured using the EQ5D. And there's lots of discussion about the appropriateness of this measure, but we were doing it from an NHS perspective following NICE guidance at the moment. And the quality adjusted life year is a combined measure of mortality and utility or quality of life over the period of time. So, QALYs were slightly higher in the two-layer hosiery group compared to the four-layer bandage group. And we think that's possibly because of the reduced recurrence in the two-layer hosiery group. So that people, if you looked at kind of the time over which people had an ulcer in both groups, people had spent less time with an ulcer in the two-layer hosiery group, and that may have led to this slight increase in quality of life or quality of health utility in this group. This means that two-layer hosiery was cheaper and conferred higher quality of life, which means it's called a dominant treatment and that it is cost effective. With this type of analysis, you don't tend to do statistical analysis to look at whether something's significant. The approach comes more from a decision-making model where it's more useful to kind of look at probabilities. So when we look at the uncertainty around this, rather than looking at p-values and confidence intervals, what the analysts do is they run simulations that kind of say, okay, if we did this trial lots and lots and lots of times, how many times would two-layer hosiery be a cost-effective treatment? How certain can we be that we are making the right decision if we say we should think about using two-layer hosiery because we think it's cost-effective? So when you run all those simulations, this is where you have higher QALYs for two-layer hosiery and less cost. And it's actually got a 95% probability of being cost-effective. So just to conclude, the results of the study indicate that two-layer hosiery seems to be as effective as four-layer bandage in terms of healing venous leg ulcers and looks cost-effective because of less staff contact time. It may be associated with a reduction in risk of ulcer recurrence, but that's a preliminary finding. Interesting, but preliminary. So whilst two-layer hosiery might not be suitable for all patients, some people find it uncomfortable and it's not appropriate for everyone, obviously, it may offer some advantages over four-layer bandaging. And that's the end.